Hi, good afternoon. Welcome to Viewpoint. My name is Lilly Neuman, and I'm the host, along with my co-host Susan Salomone, Executive Director of Drug Crisis in Our Backyard. And we'd like to welcome Dr. Ross Fishman, President of Innovative Health Systems. Thank you for being here.
Thank you. Thank you for inviting me. It's a pleasure to be here. What are we going to do today?
We're going to talk about you.
That's it. It's all about you, Dr. Fishman. How's
I don't
that?
know if I can handle all that. I prefer to talk about my program.
Yes, okay.
I'd be delighted to do that.
Today you said that today is what?
Saturday was the 31st anniversary of Innovative Health Systems.
Congratulations.
Started November 5th, 1985, and it's been half a lifetime.
That's right.
Many of my patients are a lot younger, weren't even around when we started.
Right, 1985. So now you're in White Plains?
Yes, we are.
Okay, I remember back in 1985, you didn't even know about rehabs or anything like that. Nobody was talking about treatment.
Not as much as they do today, but there was always a push to try the rehabilitation programs.
That's right, the inpatient, 28 days.
It became an industry.
That's right.
And there were a lot of spoils involved with that. We still have the overcharging that goes on today, and the lack of accessibility for people who might need it and can't afford
That's right.
it. I think we've actually created a tiered system
The very rich
for
and the very
for
poor.
the people who can afford
That's right.
more money and fancier places. And we forget that we're dealing with a basic problem regardless of race, religion, wealth, or whatever. And it's a difficult problem. It's a recurring problem.
That's right.
Yep.
And I think one of the things that we need to accept, that parents need to accept for their children from whom they suffer, is that in all likelihood, especially with the opioid problem, it's more likely to be not only chronic but lifelong.
Right.
And that we need to expect that there will be occasional lapses or relapses. We don't want to say it's part of recovery in the sense of giving permission to do it,
Yeah.
but it seems inevitable that happens from time to time. And so if the supporting cast of a patient understands that, they can be a bit more understanding, a bit more tolerant, a bit less frustrated to know that this is part of what happens. We hope for the best. We don't necessarily want to expect the worst, but if it happens, they need to fit it into the context of understanding, like other chronic diseases, things are just going to get out of control for a while. But in the beginning, it's torture. For everybody.
Right. And I think what we're doing now, we're talking about that it's a brain disease. And we're trying to help families understand how it affects the brain, how it affects the fact that this becomes a learned behavior, because parents, loved ones, how do you keep doing this over and over again? You're in jail, you're homeless, you've ruined the family, but you still keep using, because the brain, that's the way it's wired. We rewire the brain. And it just becomes chronic, and it wants what gives us pleasure, simply
The brain is sort of rewired in the sense that as a result of the continued use of these medications, there are changes in structure and function of the brain.
Yep.
They can be reversed for many people, but it's a very, very slow process. It takes a very long time. And one of the things we talk about at Innovative Health Systems is how when you hang around these diseases long enough, these conditions long enough, you kind of catch some of it yourself. So for example, we have a patient who's a prospective patient, they call in and say, I need Suboxone right away. Well, of course we won't give it to them right away, but they want it now. And we know about instant gratification.
That's right, we want it now.
Ironically, when the parents come in who are desperate, they say, we want our kids to stop now.
Right.
So they're making the same mistake.
That's right.
And
Because they're around it
I
long
think
enough.
a lot of that has to do with the fact that the families haven't been educated. And that it really is imperative that families are educated at the same time that their identified patient is in treatment. The family gets educated as to what this is that they're usually their child has. What is this disease that their child has? What are the symptoms?
Right.
Because we run support groups, drug crisis in our backyard, and we, the newcomers that come in they say their kid is, in rehab now, and they think that when their kid comes out, they're going to be better.
Fixed.
And so that still is very true, that idea that one time in and they're going to come out and they're going to be better. And so the families need to be educated while the person that is in rehab or outpatient being helped.
That's right.
But something comes before the education in a way. I'd like to give you the analogy of a DWI program that we have. A person gets stopped one way or another and is arrested for DWI. What happens then? They get arrested, they have court costs, they have to hire a lawyer, they may lose their license, they can't get to and from work. By the time they come to us, they are angry.
Right.
And they are wondering why the cops aren't after the real criminals. Right. The analogy is that by the time we get some of the family members in, they've been through such hardship that they are angry, they are frustrated, they are upset. And while education is necessary, it's not always the first thing. You need to address their emotional issues and then start to feed in the rest.
But what I'm finding out is that some programs don't have the family component that allows the family to come in, to talk about, to express their anger, to have an appropriate place to put it, to work through it. Why this person is working on their stuff, parents are able to work on theirs. And I think that's part of the education piece.
All right.
That's the education piece.
Yep.
Yeah, it's not
Giving
necessarily
them a place.
curriculum,
Right.
as much as getting an understanding of where the emotions are coming
It's
from.
therapeutic.
That's
it's a
right.
therapeutic
It's
program.
Now, I had gone through that with my son,
Right.
because I was at a place that was a good place. I kind of forgot the name of it. It was in White Plains. But we were angry because we had been through it so many times, and we couldn't do anything but be angry about it. And as much as that therapist wanted us to have a better understanding of what was happening, we weren't listening because we were so angry. You really struck a nerve when you said that, because that's exactly what we were, and we couldn't hear anything else. But what about us?
Right.
Exactly. The programs we run are called You Just Don't Understand, and both sides are feeling that the kids don't understand what the parents are going through, and the parents have no knowledge of what people who are dependent on these drugs are going through themselves.
Do you have family groups?
We are actually going to start it's a couples group for the parents of the young adults who are in program with us.
Okay.
I'm pairing up with a woman named Judy Townsend, who is a marital and family therapist. She's also a physician's assistant. And we're actually putting together the curriculum. I call it curriculum because we have an outline of how we want to proceed.
Right,
but we'll be running it therapeutically and then getting into the education so that they do have an understanding.
Right.
The CRAFT program, community reinforcement program that was put together a few years ago, takes an approach that's different from confrontation. It's more understanding and compassion. And there are some issues here about, should parents be throwing their children out of the house, or should they keep them in no matter what because you're always a parent? And that's going to be controversial.
Absolutely.
It is very controversial.
And it doesn't, there's not one answer for everybody. It's where the family's at the time, you know. And
I was involved in that CRAFT program for a while, for a short while.
Okay.
And, I think it was before its time, because really that was back in about probably 2008, 2009.
Okay.
Yeah, that I was involved in that.
Because it's almost like tough love. Do you do tough
No,
love?
it wasn't
No,
tough
tough
love.
love.
I'm saying
or.
It's either one or the other.
Yeah.
Right. They're sort of against
Right.
the
No,
tough love
so
approach.
it's tough love, and then it's that. And I guess it depends on the family and what they're...
If you can't get the family to deal with their exasperation, then you're not going to get past the tough love thing.
right.
If they can see that there's another way to do it, it may take longer, but more compassionate.
Right. Yeah. And the outcomes are probably better.
Well, what you want ultimately is to have the children or the patient and the family to maintain the relationships over time.
Right.
So they're going to have to start building things up. And if you start off with a lot of controversy and confrontation, sometimes there are wounds that don't heal very easily.
I have to tell you, though, what I love about working with adolescents is doing the family work with the family and the adolescents. And I still keep in touch with some of the families, and it just warms my heart that the families are intact and the kids are doing well, and it's great.
I'll tell you an approach that few people have tried. We've done it once or twice, and I presented it at Woodlands Temple in town of Greenberg. You bring together a parent and a child. You get maybe 6 of each. But you don't have the parents and children related to one another.
You switch them.
So you eliminate the emotional connection between them. Parents can hear where the young people are coming from, what they're experiencing, and the young people can hear the parents, their frustration, exasperation, but without that emotional stuff
Well, that's
that comes
interesting.
up.
That's interesting.
Yeah.
We did that at Excel. We'd line the parents up, and we made them switch. You couldn't sit opposite your parent or your kid, and you would talk. You'd answer the same thing, questions, and talk about what's going on. And you're right, they did hear each other a lot better than if it was their own parent.
Right. So can you tell us about the services that you offer at
I
Innovation?
was just going to say that. Would you like to hear about that? Okay, we have an outpatient rehabilitation program which runs 5 days a week, 9:30 to 1:30. We provide a lunch there. We provide specialized groups such as relapse prevention, anger management, early recovery, addiction education, a little arts and crafts time, current events.
Good.
And so there's a men and women's group and a families issues group. So that occupies the group pretty well for, it's actually 3 to 5 days, but it could be as many as 5 days.
Okay.
That's the full-time program.
All right.
The rest is what we call clinic level of services, as you're aware. We have a DWI group, both in English and a separate one in Spanish that's been on for over 20 years. We have the teen young adult program, which runs from about 17 to 22.
Okay.
And that meets a couple of times a week after school hours, with individual sessions by appointment.
And is that directed towards substance use? For the teens, is that a substance use?
This is all
substance use.
And 1 or 2 of them may be on Suboxone, which we'll get to talk about a little bit. And then we have a general substance abuse group that has a mix of people with cocaine, marijuana, alcohol.
Okay.
A few years ago, we had enough people with, I would say, alcohol only, or alcohol is the main focus, where they could have their own group, but it just hasn't been flowing that way these days. But the biggest population we have are people with opioid dependence, people who have gotten into trouble with pain medication, with heroin, and now with fentanyl and the mixture of those. We've seen, unfortunately, some overdoses, which are very tragic.
Yes.
And the odd thing about it is you'd think that would scare some people off, but it doesn't. Some of them are attracted to the substances that almost kill people. They want to get as close as they can. Haven't figured out the psychology of that yet. Excuse me. I would say about half of our patients now are opioid dependent.
Wow.
By that I mean people with heroin or pain medication issues that have chosen not to try abstinence completely.
Okay.
So they're looking for medically assisted treatment.
Right.
Methadone's been around since 1964. We started our buprenorphine program, which uses Suboxone as a brand name. Zubsolv is another brand name. Since 2008, so we've just completed 8 years of that. And what attracted us to the program was this opportunity to help people with the heroin problem in a different way. How did buprenorphine come about? There were many people going to methadone programs who were maybe better off, or they were working.
That's right.
They would come in, get their medication, and leave, but they didn't really like the atmosphere.
right.
There was a lot
The
of drug
methadone
dealing
clinics.
going on. So in Congress passed the 2000 data, which is Drug and Alcohol Treatment Act.
Okay.
And that's what set up the possibility for private physicians to use buprenorphine to treat heroin problems in their private office. The way the law reads, the way the act reads, is that the physician is allowed to do that, but must also demonstrate the capacity to provide comprehensive care, including counseling and toxicology testing.
Okay.
However, it doesn't say they have to do it. It
Right.
says they have to demonstrate the capacity,
Right.
which really means nothing.
Right.
Right.
That's why, while there are a good number of physicians who are prescribing Suboxone, they are not doing the counseling.
Right.
They're not referring for the counseling.
Right.
They're not doing the toxicology.
right.
I don't mean to paint all
No,
the
no,
physicians
no,
that way,
I know.
but there are
You
many
need
that
to
do
say
that.
it, though.
And they won't take insurance because they have
Cash.
a kind of cash cow situation.
Right.
That's right.
But they're not doing the patients
That's
any
right.
favors at all.
Right.
And so they're taking Suboxone. They have no idea whether they're selling it or not selling it, whether they're using it or switching off to heroin, as we know they do. They could be a great force to move this whole problem forward, but they're not really on the side of the treatment programs.
Right.
Our program, you cannot get buprenorphine unless you attend the
Right.
treatment program.
Right.
And we test people once or twice a week. And we can track, for example, with marijuana, we can tell if it's coming down,
Right.
and if they use, it pops up again.
Right.
So we can keep a close eye on them.
Oh, so what happens if you have someone who is, using regularly? They're coming positive for marijuana regularly.
Well, that brings us to the issue of harm reduction.
Yeah.
How do you approach this? If the conflict for us is, on the one hand, you want to treat everyone equal, but equal really has to be defined a certain way. You cannot have every patient be treated exactly
Right.
the same. And so we might have someone who we're a little bit more tolerant of using marijuana than another person, but then they can use that to say, well, what about
That's
him
right.
and what about me? We
Right.
just had this discussion Monday with the patients in my current events group. And they're saying, well, you have to do it this way or that way. And some of the patients are saying, well, you're saying that you can use marijuana, but I can't use marijuana. That's not fair. This is a struggle. And
Yeah.
as harm reduction begins to play a greater role,
Right.
and by the way, within harm reduction, abstinence is an absolute
Absolutely.
alternative.
Yes.
It's,
Right.
Yes.
option within that umbrella.
Right.
So we don't rule that out.
Right.
We still push for abstinence. I simply say to them, while you are in treatment, we are asking you not to use. We're not telling you how to live the rest of your life. You've been a social user, you've been a problem user, and if you cannot use for a period of time, when you're done with us, you have a choice.
That's right.
I can try social using, I can go back to problem
That's
using,
right, you have a
or I
choice.
can stay the way I
You're
am.
right.
But we want to give you the opportunity to experience that
That's right.
abstinence. And then you make your choice. But what we do know, Susan, is that if you can stay clean for 3 or 4 months,
right, you stay
you
clean.
begin to see the benefits
right.
of sleeping better, eating better, feeling better,
That's right.
sleep, clarity of
That's
thinking.
right.
And so if we can manage that, it becomes its own
That's
reward.
right. That's right.
And
people stay sober.
that's what we hope for.
Right. But I found with opiates that's not true.
In what sense?
That they get 4, 5, 6 months and then they relapse. Unless they're on-
I
unless they're
certainly
on,
couldn't argue with that. I think the relapse rates are very high.
Very
for
high.
opioid.
Very
Yeah.
high.
Why is that? Why does, and I could be wrong, that opiates, this epidemic seems to me different than it was in the 60s. They're starting younger, they're starting from the pills, and they're out there longer, or it's having more severe consequences. It just seems different.
There are two aspects of this. One is the social aspect where people are using, their peers are using, and when you say you're not using and I am, I want you to be with me, so
Right.
I'll offer you some, and you can succumb quite easily. But the other piece is to understand the brain aspect of it that you were talking about earlier. we're familiar with the term homeostasis, where the body tries to maintain equilibrium,
Balance,
so
right.
you stay at 98.6 temperature, more or less, whatever. Well, there's a different term called allostasis.
Okay.
And allostasis refers to the fact that wherever you started with homeostasis at a center point, that shifts, and it shifts to a new steady point.
Okay.
That's where your body becomes most comfortable. You know, when you take a drink and you're at this point, you get a little dizzy, a little woozy, whatever, and you develop tolerance if you keep using it. Well, once the brain gets used to having a substance on a regular basis, that's the way it wants to keep it.
Right.
So when the person says, I want to stop using, the body reacts in the opposite way. It goes into withdrawal. And most of the younger people who come in say, you know, I keep trying to stop. I go 2 days, then I get sick. They've used it so long enough that they've developed this new set point in the brain. And that's where the brain feels most comfortable.
So it keeps going back to that
so
point.
So frankly, if you could keep the heroin there, if you could keep the Suboxone there, if you could keep the methadone there, people can live fairly regular lives. You may not even know that someone is using pain meds or Suboxone or whatever. If they're taking them the right way, they're functioning normally.
Right.
And you only know that when things go wrong, when they move from desire to what I call desperation, and then they start to act out and get sick and get desperate and do all sorts of things.
Well, I find with heroin, there are people that are using it to get well, to get to that point where they can function through the day, night, work, whatever. And not be sick.
Right.
Well, if heroin were as long-acting as methadone, then they could take it once a day and it would be fine. But it only lasts 4 to 6 hours. They have to keep repeating the dose. Same thing with the pills.
Yeah.
So it's too up and down. And Suboxone, methadone provides the opportunity for something steady.
Do you do methadone?
No, we don't. No, methadone is run by opioid treatment programs. That's federally funded and overseen by the federal government.
How come you don't use Vivitrol?
Or do you?
Or do you, I should
We
say.
haven't used Vivitrol because our physician hasn't gotten to the point where she wants to do that. But we now have 3 resources for Vivitrol.
Okay.
One in Cortland Manor, one in Mahopac, and a psychiatrist in White Plains. So, if they would prefer that, we let them know that it's available.
It's an option.
Okay,
Good.
so who in Mahopac?
I don't have his name on the tip of my tongue, but I know he's on Route 6 somewhere, and I'd be happy to get that for you.
Yeah,
but
that would be
it's an
good because
alternative.
I've had some experience with Vivitrol. Justin was on Vivitrol. That was very good. He did very well on it for the period of time that he was on it.
The recommendation is for at least 6 months.
Right.
And the injection's supposed to last about 30 days, but it doesn't always do that because of individual metabolic differences. So I know the doctor in Mahopac will give someone naltrexone, which is the Vivitrol in pill form, for a week's supply, so that for the last week of the month, he wants the person to take that just to make sure that you don't get into that stage where you're likely to pick up.
Like
so Vivitrol is very promising.
Good.
They also have implants for that, for Vivitrol.
Well, that's what we were talking about.
It goes right under the...
I thought Suboxone did.
Actually, I'm sorry.
It's called...
They did have an implant, but they were getting some infections from that, and now they're trying to do an implant with buprenorphine.
That's
okay, all right.
Which it's better because then the person doesn't have to make a decision to take a pill every day.
Exactly.
Or take
and some people can't do it, So
some
I think
people
it's 3 months. I think it's 3 months it lasts.
Yeah, they say, no, I'm not going to take it today. And then,
Unless that's another option. That's what we talk about. Medically assisted treatment. People have to have options.
Right.
They have to. It's just not methadone. It's just not buprenorphine. It's Vivitrol. It's all these different ways to stay sober plus counseling.
I want to ask you a question because something you said in the very beginning was quite interesting to me because what's your impression of alcoholism and this heroin epidemic? Like, I get the feeling that alcohol is another drug that is very, very hard not to relapse from?
One can relapse easily from alcohol. I think my personal opinion is that the narcotic is a stronger drug in that sense. It makes a deeper impression on the brain, and it's much harder to reverse. We need to understand that we have to take the focus off the drug somewhat, because there are people who argue there's no such thing as an addictive drug. It's the drug in that person. There are some people who use heroin, there are some people who use cocaine, people who use marijuana. They're not off the rails. They sort of manage their lives.
They manage,
so what is it about that person? Is it the genes? Is it their physiology? Is it their mental status? Is it the upbringing that they've had? And the issues that they bring that are usually not the focus of attention. It's usually the drug. But every one of us has a childhood. And if you've had a problem childhood that lags behind the drug use, and then the problems that the drug use creates, you've got a range of things to deal with. And if you just focus on the drug, you get nowhere. You get nowhere. That's why the counseling is so important. It's the most
important. It really is.
Very important, yes.
Someone can say, I want to stay off these drugs. But I don't know how. So if we're going to say you can't, if we're going to ask them to remove a coping mechanism,
give them another.
We have to be able to provide a substitute.
You're absolutely amen to that one.
Which is why we offer the relapse prevention skills, refusal skills, the challenges of early recovery. We have to give them something to replace it. Otherwise, you leave a black hole.
And we have one more minute. See how fast this goes?
It's a big complaint with the mental illness and co-occurring disorders that people are taking their substance away and the mental illness is a major problem, and they use again. They relapse.
The mental illness that just complicates things for people who have the mental illness part of it as
which
well.
a big part of it.
That's right, and have to be
percentage of people
worked
that use drugs.
With together. You can't say first take away the substances and then we'll get clean and then we'll work on your mental health.
Fortunately, the buprenorphine has very little interaction with the psychotropic medications.
Perfect.
So people on those medications
That's great to know.
Can take those.
Yeah.
Now what we'll find is
gotta wrap it up.
That someone who's switched from heroin or pain pills to buprenorphine may have trouble sleeping. And there are lots of things going on inside the body. So our physician
we have to
wrap it up.
We're running out of time. Look how fast we went.
Okay.
So
is it over?
Yeah, almost.
Okay. Well, anyway, so I'll just finish to tell you that our physician may give a little bit of Klonopin to help someone fall asleep and reduce their anxiety. He never prescribes Xanax or anything like that.
Bad. We just keep talking. Good. See how fast it